Welcome to Innovation in Surgery monthly video conference. I'm Aminian, Bariatric surgeon at Cleveland Clinic. As many of you heard, new guidelines for practice of bariatric surgery in patients with type 2 diabetes have been recently published, and multiple medical organizations have endorsed them. Dr. Phil Schauer, professor of surgery and director of Bariatric and Metabolic Institute at Cleveland Clinic, has a significant role in preparation of these guidelines. Phil is going to address an important question today: how the international guidelines for metabolic surgery will affect your practice. Phil, we're happy to having you today morning.
Great, thank you, Ali. This is a really exciting time in the field of metabolic surgery. I'm going to give you a brief synopsis this morning of essentially landmark guidelines, international guidelines for the role of metabolic surgery to treat diabetes, not to treat obesity, but to treat diabetes. But first, I would like to welcome all of the sites. So, for many years, the guidelines for metabolic surgery to treat diabetes have been stated by the annual American Diabetes Association Standards of Care Guidelines. And these are guidelines that are updated on a yearly basis. And this is certainly the standard of care for the United States and North America. And I think many other countries throughout the world essentially follow these guidelines. And I'll summarize them. And this happens to be the 2016 document published in January of this year. It basically says that metabolic or bariatric surgery may be considered for patients with a body mass index of 35 or greater with diabetes. Patients need lifelong monitoring, and surgery is not for patients with a BMI less than 35, only perhaps in investigational trials. And these guidelines, which were first submitted in 2009, essentially have not been changed since that time period. And I'll point out that prior to 2009, there was actually no mention of metabolic surgery as a potential treatment for diabetes. Now, lots happened in the past several years. First of all, I want to point out, and many of you are already aware of, a very, very important consensus conference that took place in London this past September in 2015, and this was the second time an international audience of experts gathered together to review the literature, the scientific literature on the risks and benefits of metabolic surgery, and came up with what they felt was a consensus role for metabolic surgery. Now, the intent was for these guidelines to be published in Diabetes Care, which has happened this past June, just 2 months ago. And I will point out that this conference and these guidelines were endorsed by 6 of the world's leading diabetes organizations: the ADA, the European Association of Diabetes, International Diabetes Federation, Diabetes UK, the Chinese Diabetes Society, and the India Diabetes Society. Now, I do want to acknowledge my colleagues to the left, David Cummings, Lee Kaplan, Francesco Rubino, and also want to particularly acknowledge Dr. Rubino, who was the lead on this development conference, spent many, many hours putting this program together. Now, the first conference took place in 2007. Many of you may recognize that and may have actually attended. This conference was the first time ever international audience really gathered together. And frankly, at that time, the audience, which was primarily endocrinologists, this was the first time they had ever really had much knowledge or information about metabolic surgery. So it was really an introductory conference. And then fast forward to 2015, some 8 years later, a lot of progress has been made. And this is the conference and the attendees from the London meeting in 2015. And I can tell you, I don't have time to mention all the luminaries in this group, but some of the world's sharpest minds in diabetes are in this group, for sure. Now, as I mentioned, just 2 months ago, in June, Diabetes Care, which is the main publication for the ADA, the entire issue of Diabetes Care was devoted to surgery. You can even see the cover photograph there demonstrating a surgical procedure, but the entire issue is devoted to metabolic surgery and essentially the proceedings of the London 2015 Consensus Conference, and most importantly, the new guidelines are actually published in this document. Now, I would urge the surgeons, every surgeon who has an interest in this area should really download this document and really identify and understand these articles very well. Here are the 12 articles. I'm not going to go through all of these in detail, but they cover numerous aspects of metabolic surgery, from scientific mechanisms to clinical outcomes and many other important clinical implications of surgery for treating type 2 diabetes. So I urge you to take a look at these important articles. Now, I've highlighted 3 of them. The first one in yellow here is essentially the summary of the guidelines. Okay, metabolic surgery in the treatment algorithm for type 2 diabetes, a joint statement by international diabetes organizations. The other 2 that are in orange are a summary of the scientific literature, part 1 and part 2. So I urge you to, particularly if you're going to look at any of these, those 3 articles. Okay. Now, this here is the title page for the guidelines. Again, the guidelines were endorsed by the American Diabetes Association, and I will quickly add nearly 50 other international professional societies, including most of the world's diabetes organizations, many surgical, many gastroenterological, many other related specialty groups have endorsed these guidelines, and the guidelines were co-authored by multiple luminaries and particularly ADA delegates. I'm going to summarize very briefly 2 of the major articles from this paper which focus on clinical outcomes. Okay, obviously we're talking about metabolic surgery. Everyone in the audience today is very familiar with these 4 major operations for metabolic surgery used throughout the world with a varying degree of frequency as shown below. Now, much of these articles summarize the outcomes of these 11 published randomized controlled trials comparing metabolic surgery with medical therapy for type 2 diabetes. And this is the biggest advance in our field in the last few years. And prior to about 4 or 5 years ago, there were very few, essentially only 1 randomized controlled trial, and now we have 11. Okay, and I would just briefly sort of review this table, which lists on the far left column the authors. The BMI range did include a fair number of patients with a BMI less than 35. The designs were quite variable, comparing a variety of procedures, mostly gastric bypass, a few bands. There's 1 study with the sleeve gastrectomy. The sample sizes were modest. The largest trial had 150 patients. That's the Stampede Trial. And the follow-up varied anywhere from a couple years up to 5 years, which is the Mangroni study. Most of these had a primary endpoint of some degree of remission or some degree of a target hemoglobin A1C. But the outcomes were quite remarkably consistent in that nearly all of these studies, with only 1 exception, demonstrated superiority of surgical therapy to medical therapy for glycemic control. And the 1 exception was the second study from the end, first authored by Dr. Ding, which was basically a gastric band study compared to medical therapy, and that study did not have statistical significance in showing banding superior to medical therapy. Now, this is a forest plot. I think many of you are familiar with forest plot constructions. This is a way to compare multiple studies, and you can see on the far right surgery versus medical right here, with 0 being both therapies being equal. You can see here that essentially all of these studies, with the one exception of the DING study, demonstrated that surgery was superior in terms of producing a greater mean difference in hemoglobin A1C improvement compared to medical therapy. Okay. In addition, in June at the American Diabetes Association, there was presented a new RCT conducted in India, comparing gastric bypass versus lifestyle intervention. And this study included patients with even lower BMI than we're used to, a BMI from 25 to 35. And this study also showed gastric bypass to be superior to medical or lifestyle intervention therapy for type 2 diabetes. Now, I just want to focus on 2 of the randomized controlled trials that are noteworthy. This one by Dr. Mangroni and Dr. Rubino was conducted in Italy. It was published in Lancet last year, and this is the first study with 5 years of follow-up, so showing relatively long-term durability of surgery versus medical therapy. This study involved gastric bypass, biliopancreatic diversion, compared to conventional medical therapy. And the 2 graphs below first show you the change in body weight, and no surprise, you see both surgical procedures, the Roux-en-Y and the biliopancreatic diversion, quite superior and remarkable in terms of improvements from baseline compared to conventional therapy. And the conventional therapy did achieve a modest weight loss, but fairly modest. The next graph shows you the rate of remission at 2 years and at 5 years. And you can see in the medical treatment, there were no remissions. Remission being defined as reaching an A1C of 6.5% or less without the use of medications. This was achieved in a very high percentage of patients at 2 years in both procedures, and there was some decrease in that remission rate at the 5-year mark for both procedures. But however, at 5 years, between 40 and 60% of the patients were still in remission with gastric bypass or the biliopancreatic diversion procedure, which is quite remarkable. These graphs really quickly show changes in overall cardiovascular risk. This is a Framingham risk score, which is a general way to calculate overall cardiovascular risk, which is really the ultimate goal for these procedures, to reduce cardiovascular endpoints like heart attack and stroke. And then the other one shows you the changes in medical medications, particularly cardiovascular drugs, with surgery compared to medical therapy, and you see a very dramatic reduction in the requirement for cardiovascular drugs like antihypertensives and lipid-lowering agents. Now, I also want to highlight the study that I was involved with, the Stampede Trial. We have published our 3-year results in 2014, and we presented the 5-year results at a conference this spring, and the study is currently under review for publication in a major journal. And our 5-year outcomes were quite similar to the 3-year outcomes. And here, comparing the gastric bypass, the sleeve gastrectomy, with a more intensive medical treatment strategy, you see that with the medical therapy, there is a fairly high degree of recidivism or relapse, such that most patients are back near to their baseline A1C. But with the surgical therapy, for the most part, very significant reduction in A1C, which appears to be quite durable out to the 5-year mark. This graph is also very important because we're interested in those patients with the BMI less than 35, and you can see that here, surgical patients with the BMI less than 35 enjoyed the same type of improvement in A1C as patients with the BMI greater than 35, suggesting that patients in this lower BMI category equally benefit and perhaps should also have access to this type of therapy as well. One important endpoint, which was not successfully demonstrated in our study, was a change in either retinopathy or a nephropathy. And this briefly shows you changes in albumin-creatinine ratio, and although there was a significant decrease in albumin-creatinine ratio after sleeve gastrectomy and gastric bypass, we did not see a significant change in albuminuria or retinopathy at the 5-year mark in this particular study, probably because of our sample size being insufficient and perhaps not having a long enough follow-up. I will, however, quickly add that at the ADA meeting in June, the SOS group presented their long-term data on rates of retinopathy and nephropathy, and both of those were dramatically reduced in the surgical arms compared to medical therapy by more than half. Both retinopathy and nephropathy were reduced by more than half in patients who had surgery compared to the non-surgical control groups in the SOS study. And finally, one very important clinically relevant issue is this issue of patients with a BMI less than 35 with diabetes who until recently have really not had access to surgery by most guidelines. And I'll point out a review of this by Dr. David Cummings and Ricardo Cohen in that same issue of diabetes care. This is particularly important since most patients with type 2 diabetes, somewhere around 60% of the population with type 2 diabetes actually have a BMI less than 35. And this is a review of all the randomized controlled trials comparing surgery and medical therapy based on their BMI. And you can see here that for those studies that had an average BMI less than 35 compared to those that had a BMI greater than 35, you can see that regardless of the BMI status, the overall effect on changes in hemoglobin A1C and glycemic control still favored surgery essentially on an equal basis. So this is further evidence, multiple randomized controlled trials showing that BMI less than 35 down to a BMI of about 27, that is, was equally as effective as BMI greater than 35. So what are the guidelines? And I want to briefly review them and then open up for discussion on some of these key points and what these guidelines actually mean. So let me just review them quickly. Number one is patients now, according to this international conference, it's recommended that for patients with a BMI greater than 40 and type 2 diabetes, that surgery should be recommended. Surgery is also recommended for a BMI greater than or equal to 35 with inadequately controlled hyperglycemia. Surgery should be considered for patients with a BMI of 30 to 34.9 with inadequately controlled hyperglycemia. And then finally, surgery should be considered for patients of certain ethnic origin, such as Asians, perhaps other ethnic groups, with a BMI as low as 27.5 with inadequately controlled hyperglycemia. Now, these are 4 of some 20 different recommendations that were made. I picked these 4 out because they're probably the most impactful. They have important clinical implications. And I think the goal for this morning is for the surgical audience here to discuss the implications of these on the practice of metabolic surgery. And I want to finally go back to where we just came from, and that is the guidelines up until this time, and we can perhaps compare how different they are, because the 2016 guidelines from the ADA suggest that surgery may be considered for a BMI greater than 35. Obviously, patients need lifelong monitoring. Surgery is not for patients with a BMI less than 35 unless in some type of investigational trial. So it appears that we have come a long way with these new guidelines, and obviously some very significant implications are at hand. So, Ali, perhaps we can get some feedback from our group regarding perhaps this first point.
Sure, yeah. So we see the tone is totally different. So now we have for the BMI over 40, the guideline says recommended, but previously it might be suggested or it might be considered. So let's go to the other side. So we're seeing Cleveland Clinic at Western. Hi, Sam. We can't hear.
Hello, can you hear me now?
Yeah, we can. Good morning, Sam.
Good morning. Good morning. How are you? Great presentation, Phil, and congratulations on that remarkable work. I think let's go back to the point. I know this is a very short conference. It is an extremely important. It's amazing that we have finally come to the point that we're getting the endorsement of the medical community. I think that is a game changer. It's always been known by surgeons how good the surgery is for many reasons, but to finally get the endorsement, specifically the diabetic community, which we know how closely associated obesity is already a remarkable achievement. Now, coming to the specific guidelines of all of them important, and maybe one overlap with the ones already being established, but the one that finally includes the BMIs from 30 to 35 also will increase dramatically, at least in our case, our patient population. It's always been questionable, and we try to keep it only for self-pay patients in this way category. But once we finally have the endorsement of some guidelines of the medical community, this can put a lot of pressure in insurance companies, which we have come down here in Florida to be the main gate for access to care. Diabetes is becoming the gate to get these surgeries kind of approved and pushed to the insurance companies, and we're doing that through the legislation, currently working on it. So I think this is a remarkable guidelines. It is a great start. I think we need to start pushing more for lower BMIs overall in this kind of surgery, but the amount of patients that are covered in this group is going to definitely increase and improve the access to care and the practice here, at least in our community here in Florida.
Thanks, Sam, for your comments. So let's go to Duke.
Yeah, hi, this is Dana Portnier.
Hey, Dana,
I just want to. Good morning. I just want to mimic that we appreciate all the phenomenal work that's gone into creating these, what for our field are awesome guidelines, and long overdue. I think our field has long focused solely on obesity, and obesity has quite a bit of bias related to it, and I think getting on to recognize all the metabolic components of what we do is phenomenal and is going to really help us expand our pie. Serendipitously, the day after these guidelines came out, I had a meeting with our Duke HR group regarding benefits for our Duke employees regarding bariatric surgery. And I quickly that night made these up into some slides and presented them in conjunction with an internal review of cost analysis of our employees surrounding bariatric surgery. And our cost analysis showed significant cost savings to the insurer, our local insurer with bariatric surgery, and then these guidelines were kind of icing on the cake. So we've made the recommendations for them to fully adopt these and are going through the process to make that happen. I do have a couple questions for potentially Phil to get his opinion on, which is one of the pushback from the insurance group is that they, in looking at the recommendations around lower body mass index for the Asian subset of patients, they were uncertain about how they might go about implementing something like this, and that seemed to be somewhat problematic. And then the other there was a question about do we need to do lower BMIs anymore under any sort of IRB protocol? And I'd be curious to hear what people's thoughts are based on these new guidelines about whether or not we need an IRB protocol to do a BMI less than 35 with diabetes.
Yeah, those are two very excellent points, Dana. First of all, regarding the last recommendation, which refers to, which brings in ethnicity into this, and this has been very well scientifically documented, that patients of certain ethnic origins, particularly India, the Far East, China, and similar countries, genetically behave differently. They tend to have more virulent diabetes at lower body weights related to how they store body fat, more likely to store visceral or truncal body fat, which is much more metabolically active. And so this panel of experts, again, I want to emphasize that some 2/3 were non-surgeons. These are world-class endocrinologists from all over the world, including China and India. They felt pretty strongly that patients with this type of genotype/phenotype should be treated differently. And I think it also speaks to the point, this new study that was just presented in June that was conducted in India by David Cummings and Shashank Shah, included Indians with a BMI from 25 to 35, and they showed very similar results with surgery being superior to medical therapy. So it may be somewhat problematic in terms of healthcare delivery to identify a person who, the definition of this type of profile. After all, most of us have a variety of different, ethnic genealogy, but it does point out to the fact that these patients do behave differently. Your second point, I think, is regarding IRB. I think the IRB requirement, from 30 to 35, this document is about as close to a standard of care document as you can get. So I think surgeons can very comfortably say and stand on high ground that if they're performing, metabolic surgery on patients with a BMI of 30, 31, and the patient is not well controlled with medical therapy, that they are well supported by the evidence and strongly endorsed guidelines. So I do not think an IRB is required at this point. Now, it's a whole other issue as to whether or not insurance is going to pay for that, and that's the next phase. But I think we do not need any IRB approval. Does that answer your question, Dana? Do you have any follow-up?
Yeah, that certainly does. I appreciate it, and I think I think that was exactly kind of the answers I was hoping to hear. I think we need to go all aggressively pursue our payers now and try to get coverage in this realm, and so appreciate the hard work you've done.
Great, thanks, Dan. One last thing, I do applaud your effort locally at Duke, and I can tell you we did the same thing actually a few years ago at Cleveland Clinic with our employee plan, and I would alert our surgeons, this is an area we have lots of influence in our own local environment, and many of us are at academic centers or involved with hospital policy. I would urge you to go to your hospital employee plan and talk to them about these guidelines. And we were successful 2 years ago at Cleveland Clinic. I think we were one of the first who was able to get an indication for surgery or coverage for surgery for patients with a BMI as low as 30 if they were not well controlled on medical therapy. So I hope your efforts are successful, and I'd love to hear more later when you get a final answer from your health plan.
Yes, sir.
Okay.
I have a question, Phil. So for this low BMI threshold for the Asian or Indian, does it implicate to those patients who live in Western countries, or is just for patients who live on those countries on the
Well, I think the premise, and the genetics are not well worked out yet, but it's really a genetic predisposition. So if you have an Indian person that moves to the United States, or if you have someone from China that moves to the United States and they have diabetes, they tend to behave the same. In fact, our culture is more obesogenic than China. So they may be even more vulnerable to their predisposition to diabetes.
Thank you. Okay, let's go to Geisinger Clinic.
It's the question regarding the impact on our practice here. We've had for 1 year, I think we've had coverage in GHP, our own internal health plan. And Dave and I were just talking. I don't think any of us, Tony Petrick included, have actually seen a patient yet that falls in the category of BMI under 35 and diabetes. And so we were just talking about how are we going to change that. And so I think that we have a lot of tools in Epic, smart tools that will allow us to disseminate the information to the primary care physicians. I mean, right now, any patient that comes to them that has a BMI that will qualify for bariatric surgery prompts come up to tell them that they should consider a consult with our GI nutrition folks and with bariatric surgeons. So I think if we change those smart prompts to include these new recommendations, that'll be one area that'll help us out, and certainly we're going to have to disseminate the information to our endocrinologists friends and give them some education, and also the other primary care doctors kind of going around and doing a horse and pony show for a few months to try to educate them. But I think really the insurance issue, just like sleeve gastrectomy, as soon as the dam broke with one insurance company, that wasn't ours, it wasn't GHP, that really just opened the floodgates for the sleeve patients, and I think the same thing's going to happen. Once one of our major players makes that jump, we're going to see a huge increase in volume.
Thank you. So, Dr. Schauer, what's going to be the next step now, how we can disseminate these guidelines in the medical community?
Yeah, well, I think I applaud the folks at Geisinger because they are using modern age technology. I mean, all of us are somewhat slaves to the electronic medical record, but we can use that very effectively by including such prompts to primary care physicians. When a patient who meets these criteria is seen by a primary care doc, these types of electronic prompts can come up just to alert the physician that surgery may be an option if they meet these criteria. And we've been successful at the Cleveland Clinic doing that with obesity. We have prompts for the primary care docs if a patient has a BMI greater than 40 or 35 with comorbidity, but these could also be used for diabetes as well. So I applaud you guys for looking into that. So I think a lot has to be done in terms of addressing the stakeholders here, and perhaps we could address that in just a minute after we get more feedback from some of the other groups. But referring physicians, how are we going to get this message across to patients who obviously have to make that personal decision, and then the payers as well who are paying for it.
Okay, thank you. Let's go to Sumo Health. Adrian Dan should be there with his surgical colleague.
Can you guys hear us?
Morning.
Good morning. I apologize you can't see me. Our microphone is not within the camera range. It's probably for the better, though. You can see my much better looking partner, Dr. Zografakis. Phil, thank you for the opportunity. First, I just want to congratulate you and the entire DSS2 organizing committee, Francesco, David, Lee, for just an incredible accomplishment. This has certainly been something that's been overdue. I had the privilege of attending DSS2, and I see it as remaining a huge historical marker on our subspecialty. So we have one comment, and we also have one question related to that. First, our comment is that while the proponents are more and more numerous, we all know that the skeptics are out there. There's irrefutable level 1 evidence, randomized controlled studies that you've talked about, and we know that surgical therapy is the most efficacious, the most effective therapy for type 2 diabetes. I'd like to point out that if this was a pharmaceutical agent undergoing the standard FDA approval process, an agent with similar efficacy, cost, and safety profile as bariatric surgery has, I can't imagine that any discipline or third-party payer would not make it accessible to their patients. And that's something that is different with regards to the actual surgery that we can provide and the therapy that we can provide. So if you could comment on that. But with that being said, as bariatric professionals, we have to be, not in a passive way, but in an active way, the greatest advocates for our patients. The insurance companies are going to drag their feet. They are not going to embrace this with open arms. It's going to be a very slow process. So the one thing I'd like to specifically ask you, particularly as someone who's been through this before with the CMS decision to cover bariatric surgery and has helped get us to where we are today, is how does the bariatric surgeon on a local and a national level, aside from joining the ASMBS and a committee like the Access to Care Committee, but on a local level, how do we take this fight to the third-party payers, and how do we take this fight to the healthcare policymakers to make this a reality for the people who need this type of therapy? Thank you.
Okay, those are excellent points, Adrian. Your first point was, I think, related to the strength of the science supporting surgery. And now more than ever, with 11, actually 12 randomized controlled trials, high degree of consistency with surgery superior to medical therapy. And also, I didn't really talk about the safety profile, but in almost 1,000 patients in those 12 randomized controlled trials, not a single death, not a single cardiovascular complication. And certainly typical complications that we see, anemia, some GI side effects, strictures, occasional leak, and so forth. But fortunately, very minimal long-term morbidity. So with that safety and efficacy profile, we have very strong evidence. Now, I'll point out though, there are some gaps in literature still. We have follow-up up to 5 years. Diabetes is a lifelong disease, so it is important for us to get a better idea on the relative effect of surgery compared to medical therapy much beyond 5 years, and then importantly the effect on hard clinical endpoints. It's not just about hemoglobin A1C, which we know is a surrogate marker of disease. It's actually about whether these procedures will reduce heart attack, stroke, mortality. Now, aside from these randomized trials, we have the SOS and about 9 other comparative but non-randomized studies that also strongly suggest that surgery can reduce these clinical endpoints. But we don't quite have that level 1 evidence for that particular important endpoint. But again, to summarize, the literature and the scientific evidence has never been stronger to support surgery. Now, regarding what can surgeons do, and I'll just go back to pointing out things that Dana and his group at Duke and others have done, is you can affect your local market. I know you guys work in a medical system, SUMA. We just heard from Geisinger. So all of these systems employ thousands of patients. Cleveland Clinic, we employ 40,000, but we cover 150,000 lives. So you can have impact on your local healthcare coverage plans. There will be in the near future an effort by ASMBS and other leading organizations to begin the dialogue with CMS and in addition other payers. I spoke a couple years ago to one of our local insurance carriers and they said, well, when the ADA includes surgery in their guidelines, that's likely when the insurance industry will change over. So I'm quite optimistic that in the next year or 2 or 3, we're going to see things change dramatically because of the strong evidence. Let's hear from some others.
Thanks. So, Phil, I have a question.
Oh, one last thing. I do want to recognize, Adrian was shy about this, but Adrian took the lead on an upcoming edition of Surgical Clinics of North America. All surgeons are very familiar with this journal, and this issue is going to be coming out in the very near future. I think some of the articles are already published, e-published, and the entire issue is devoted to metabolic surgery. Adrian, can you talk a little about that, please?
Phil, thank you for the plug. The check is in the mail. It's been just an absolute honor to be able to contribute and bring together really some of the brightest minds in metabolic and bariatric surgery. I want to point out that for the first time ever in the history of a series that is more than 100 years old, metabolic surgery takes precedence in the title of a Surgical Clinics North America issue. It is actually called Metabolic and Bariatric Surgery. And every single major organizer of DSS2 was an invited author with great articles, obviously by yourself and by Francesco, and it covers a huge range of topics in metabolic surgery. It's very comprehensive. It's wonderful for the graduating chief resident, practicing surgeon, the fellow in minimally invasive and bariatric surgery. And it also covers very important topics, and I want to plug your article, Phil, especially on the socioeconomic impact that metabolic and bariatric conditions have on our society, because I think so many healthcare policymakers will utilize this source as a comprehensive review of why they need to pay attention to our cause. So thank you again for the plug. I appreciate it.
That's great, Adrian. Congratulations. So let's check with our colleagues at the Ohio State. Dr. Needleman, our colleagues.
Yeah, can you guys hear us?
Yes, good morning.
Thanks, this is great. I think, we talked so many years ago about trying to get papers about the success that we have with bariatric surgery into the medical literature versus the surgical literature, and it's great to see that come to fruition and see these major organizations really endorse what we've known and what we've done for so long. I think we do, like everyone said, we're going to have major challenges. I mean, in Ohio here, even Medicaid, still your BMI has to be over 50 and on insulin before they'll even consider you for bariatric surgery. So we're still trying to get these types of payers back to the 2009 guidelines. We don't even have them on the modern guidelines. I mean, I know lap bands have been FDA approved for BMIs over 30, but I've yet to have any insurer actually cover that as an operation. So I think we got our work cut out for us, but I hope Phil's optimism is true that we're able to get these things covered. I know within our own health plan we still have challenges as well, but I mean, we're excited moving forward. I think we've really come into our own here, and with these new recommendations and guidelines, and we'll try to use them within Ohio and nationally. I'll make one other point that the exchange programs also for the Affordable Care Act continue to not cover even medical weight loss in most states right now, and I think we need to work hard to make sure that those guidelines get changed as well. And one more point that I'll make too is I've been recently on a panel for the Ohio Commission for Minority Health, and there continues to be great disparities in obesity and diabetes care in Ohio, which is what we study, but also nationally. And hopefully these guidelines, focus mostly on Asians, but there's other minority populations as well that are not getting the care for obesity and diabetes that non-minority populations do. And I think that's something maybe we can continue to address with these guidelines as well.
Yeah, I think, Brad, you make a lot of very important points. Even with sort of existing, guidelines, there are huge gaps in coverage from state to state. And you talk about government payers, Medicaid, and there's wide disparities. And that's unfortunate. So we do have a lot of work to go. Perhaps, as alluded to before, one of the biggest sticks that we have is the economic benefit. So we're now getting clear scientific evidence of efficacy, safety, and then when you add to that cost savings, then it becomes a much stronger argument. If you look at the relative long term, 3, 5, 10 years, especially patients with diabetes, study after study has shown a strong economic return. So I think it's a matter of just putting the argument forward. I'd like to ask you, though, at Ohio State. Ohio State's a big system. You have an employee health plan. What is your current coverage policy? Does it stop at 35? Are you entertaining or proposing that it be lowered to 30 for patients with diabetes?
Yeah, I mean, currently, we were a tough health plan. I mean, it wasn't until a couple of years ago that we were able to even change the year-long requirement for medical weight loss before they would be candidates for surgery. So we've got that down to something a little bit more acceptable. This still follows the standard guidelines. Our challenge actually happens to be the great out-of-pocket expense that we continue to have here that we're trying to change. Even though bariatric surgery is covered here, the out-of-pocket expense is still about $6,400 for a patient. So we're still seeing great disparities in that as well, and that comes from a variety of different reasons. But actually, the University Staff Advisory Council is the one that made that recommendation, and it was based on actually a lot of misinformation about bariatric surgery and some individuals that didn't have bariatric surgery themselves, but had some negative thoughts about it. So we have an uphill battle here. We continue to fight that fight. We continue to collect data on healthcare costs, and when the insurance plan comes and told us at one point, well, a lot of your patients have a lot of reoperations, and I would say, and they would show the percent that have reoperations, and I would say, well, what are those reoperations for? Because it's very often that these patients are now able to get their knee replacements or plastic surgery or other options that they weren't able to get before. And they said, well, we don't have that data. We'll come back with that data. And then they never came back with that data. So I'm suspecting that they're showing me what they want to show me, but not the real information. So I'm actually got myself on the Health Quality Improvement Committee for the health plan, and I'm hoping that that helps me to make some headway in changing some of the policies that we hear at Ohio State. But it continues to be an uphill battle.
Yeah, and as you point out, there's still challenges, even convincing doctors who are involved with health plan coverage policies. But one recommendation I'd make to all who are attempting to do this is bring an ally with you. Bring, like we did at Cleveland Clinic, the head of endocrinology, the head of cardiology, and get them to be allies with you. And that's a much more powerful strategy than just a single surgeon or a surgical group going to the health plan.
Okay, thank you. So let's have the comments of our colleagues at Johns Hopkins, Dr. Schweitzer or Magnuson, Maureen.
Hi, Phil. Many people had to leave for the operating room. This is Gina Adralis. I recently joined Hopkins from Dartmouth. I have a question. So we did before I left Dartmouth, a similar study, just echoing what was done at Duke, and showed as well not only decrease in cost for patients having bariatric surgery compared to a similar obese cohort, but also a marked decrease in healthcare utilization with a 17-fold difference in emergency room visits, for example. My question is really about the type of surgery they're offering, looking at results with sleeve and gastric bypass, particularly for patients who have difficult to control diabetes. Your study showed good results for both groups of patients with surgeries, but there's some studies looking at shorter term results that show a more durable effect with a bypass. So I'm wondering about your stance on that.
Yeah, that's good. It's a very important clinical topic because surgeons have to advise patients on not just bariatric surgery, but which procedure. So, the game is really gastric bypass versus sleeve gastrectomy. Our randomized trial showed that at 5 years, the changes in hemoglobin A1C were fairly comparable with the two procedures. However, number one, the study was not powered with 150 patients total and 50 in each group, was not powered sufficiently to demonstrate clinically significant differences between the bypass and sleeve gastrectomy. And all the major endpoints, the gastric bypass performed better than the sleeve gastrectomy, but it was not statistically different. Number two is the patients who had gastric bypass achieved that glycemic endpoint with fewer medications, diabetic medications, than the sleeve gastrectomy patients. And number three, patients who had gastric bypass had better weight loss than the sleeve gastrectomy. So, based on that randomized trial, I think there's some significant advantages of the bypass over the sleeve, and hopefully with longer-term follow-up, we will see the importance of the durability effect. There are a couple other randomized controlled trials. They tend to, again, suggest the bypass favoring the sleeve. And then we just published, and Dr. Aminian was the first author on our long-term experience with sleeve gastrectomy here at the Cleveland Clinic. Ali, do you want to summarize that just briefly?
Sure. So we saw it was just a single-arm study, long-term cohort of patients who had sleeve, and we saw significant improvement in cardiometabolic risk factors, but the cure or long-term complete remission occur very infrequently in cohorts of patients who have sleeve. So let me ask you this question, Phil. What does this guideline say about the choice of the procedure? Is that clear in this guideline?
Yeah, the guidelines are somewhat agnostic to the procedures, simply because there was not significant comparison data to show strong superiority of one procedure or another. The exception is with the gastric band, which is somewhat irrelevant now anyway because the use of the gastric band has dropped so dramatically. And the use of the BPD is so infrequent that it is somewhat, clinically insignificant in this realm. So it's really between the bypass and the sleeve. And right now the data is not strong enough to clearly state that one is vastly superior to the other.
Okay, let's hear from Tom Regula. I think he's connected from Poland. Tom, can you hear
Hello?
us? Hi, Tom.
Yes, I can hear you very well. Hi, how are you? Welcome from Poland. This is beautiful sunny afternoon in Poland. I really enjoy the conference. I think it's a phenomenal initiative that Phil and you.
These guidelines, Tom.
So I think it's really important for the international community. There's about 3,000 surgeons watching us from all over the world through International Bariatric Club. So when we provide them, it's really important. I have a couple of comments. First, do you think it really makes sense to keep metabolic surgery slightly separately from mainstream bariatric surgery in terms of setting up a separate sort of unit or group? My experience with this kind of thing is very good. We set up something called Metabolic Surgery Center, which works in a very close cooperation with endocrinologists. This is what Phil mentioned, that having good allies from this work is really, really important. Especially when we're dealing with very low BMI patients and we really don't do weight loss surgery. This is typical metabolic surgery. Maybe in the future it will make sense to create a slightly separate units of something called metabolic surgery. I know you feel and Francesca have good experience with this. So my question is, do you think in the future this kind of movement will make sense and will be justified by administrations in the hospitals?
Yeah, Tom, that's a very good point. And the American Society for Metabolic and Bariatric Surgery added the term metabolic to our name back in 2007, and it was for this very reason, to more broadly incorporate the concept of the metabolic effects of our procedures other than just pure weight loss alone. It's my opinion that there is lots of overlap between obesity changes and metabolic effects. So it would be very difficult to completely divide an organization or a discipline in two. So I think that we're all, one family, and essentially I think metabolic surgeons are bariatric surgeons and bariatric surgeons are metabolic surgeons. However, there are some clear distinctions, and as you pointed out, in this lower BMI group where the mechanical effects of obesity, orthopedic issues, some of these other, maybe GERD, for example, are less of an apparent issue, and more the metabolic effects seem to dominate. There are some clear distinctions here, perhaps with regard to the procedure, certainly with regard to the evaluation and follow-up. So I think there's definitely a role to distinguish, more focused metabolic endpoints in certain populations of patients. But I think that we are all, surgeons are all in the same family, and also should continue to work together. A few years ago, there was a notion that we should create a separate society of metabolic surgeons, distinct from ASMBS, and I would strongly disagree with that approach. There's plenty of room in this large tent for everybody.
Okay, good. Let's get back to on Arundel. I think we have video connection now. Morning.
Good morning. Unfortunately, Dr. Park is not with us today, so we also can't provide a lot of insight for you. But I did have a question with regard to the
Sure. So can
guidelines. Is there a
increase the volume?
Yes, if you have just a quick question so we can...
Go ahead.
do the guidelines speak at all about age of the patients, particularly the pediatric population?
So, is there any recommendation for adolescents and pediatric?
That's a great question. That came up very early on in organizing the Diabetes Surgery Summit, the issue about pediatric, age 18 or less. And it was felt that the evidence wasn't sufficient enough to really dive into that in detail. However, the evidence is mounting. A recent NIH study was published showing some long-term effects, metabolic effects, as well as safety. So perhaps in the near future, we may see either a separate consensus conference focusing on the pediatric population, or that particular subgroup addressed at a future consensus conference on metabolic surgery.
Okay, here. So we have a question from Geisinger Clinic. Can you get back to Geisinger?
Hi, Cassius. Thanks, Phil. It's
Yes.
John Gabrielson and David here. So the question is, should the biliopancreatic diversion duodenal switch have a place in the conversation here of the procedures that you would potentially offer? Because we've talked about sleeve and bypass only at this point.
Yeah, it's a good point. And just briefly, based on several studies, and particularly the Mangroni-Rubino study, there's no question that it's quite effective. And frankly, from a metabolic effect, it is probably the most effective procedure that we have for diabetes control. However, the metabolic, or I should say the nutritional consequences of the procedure seem to outweigh the benefits. And if you even look at the small Mangroni study, where they had only 20 patients in each group, at 5 years, you see a significant percentage of the patients with the biliopancreatic diversion with significant metabolic bone disease, some issues related to their protein stores. So and besides the fact that it's only been utilized in 2% of the population, and the extent of follow-up and maintenance requires a dramatically different way to manage these patients. I just don't think the data is sufficient right now to recommend that as like the procedure of choice, for metabolic disease, for diabetes.
Okay, so Phil, I have a question. For the category of patients with BMI 30 or 35, these guidelines suggest surgery for patients with inadequately controlled diabetes. How can we define or find these inadequately diabetes? Is that a clear definition for that, or?
Right, that's a very good question. Perhaps that's the question we should end the program on. There was a lot of debate at the Diabetes Surgery Summit Consensus Conference on trying to nail down a definition of inadequately controlled diabetes. And among the 30 or 40 leading endocrinologists, we really couldn't reach a consensus. There was a wide degree of variability in what these experts thought would be considered adequate or inadequate control. But every physician, every endocrinologist has to come up with what they think that terminology or definition would be. And some of the things that have been proposed would be to base it on hemoglobin A1C. So perhaps a hemoglobin A1C of 7% or greater is technically not adequate control. The ADA guidelines suggest trying to get the patient to 7 or less. So with some degree of intensive medical therapy, perhaps over some period of time, maybe it's 1, maybe it's 2 years, with escalating use of drugs, maybe including insulin. If the patient cannot be well controlled at 7 or less, maybe it's 7.5, then that would be, I think a reasonable target, or at least a strategy to sort of base your therapy around.
Yeah, but it's going to be very controversial, because we know that if we proceed with surgery in early stage diabetes, we see significantly better result compared to wait for 10 years and do surgery on patient who exhausted all the beta cells. So it's going to be very controversial issue.
Yeah, and that is going to continue to be probably one of the most debatable topics. We know that if we intervene relatively early, when you have a fairly robust beta cell population, we can put many patients into long-term, maybe even lifetime remission. That's a lot of patients, right? Some of those patients might do just fine with medical therapy, right?
Sure.
If we just wait till the patient has, very poorly controlled diabetes, then, perhaps we'll make them better, but we will eliminate their chances for remission.
Right. Okay. Any questions from other sides? Okay, so thank you everyone for joining us. Thanks, Phil, for this nice presentation. Next month presentation will be on September 2nd.